And Helena Hansen also is the associate director of UCLA's Center for Social Medicine. She received Robert Wood Johnson Health Policy Investigator Award, NIH R01 Awards, Kaiser Permanente Minority Leadership Award, and teaching awards from NYU. She's authored 3 books, which is something anthropologists do. I'm very jealous of that. The first is Addicted to Christ, Remaking Men in Puerto Rico, Pentecostal Drug Ministries, Structural Competency in Medicine and Mental Health, a case-based approach to treating the social determinants, and a forthcoming book, Whiteout, How Racial Capitalism Changed the Color of Heroin in America. She's also the leader of the national movement for training clinical practitioners to address the social determinants of health. She and Jonathan Metzl called this structural competency, and we're all working to be steeped in it. So welcome, Helena.
Thank you for such a generous introduction. And what an honor it is to be on this call with so many people I admire. And Dr. Malaspina, really my inspiration and somebody who I'm constantly citing as a very well-regarded and highly accomplished life scientist who actually takes the biological seriously, takes social determinants seriously, and is working to operationalize that interface of the biological and social, which is probably where I'll end up in this talk. So I really always have appreciated her work, and Paul Rosenfield. And there is actually a member of my team on this call who I've known, he's now a Mount Sinai medical student, but I've known him since he was a freshman at NYU. So I can claim him, Parth Patel. Thank you for coming. It's just amazing to be reunited with so many important people in my life. So I want to thank also the other members of the Just Talks planning committee, because this has gone so seamlessly. And want to start by, let's see if I can get my slides up. Okay. So I'm going to be sharing research that I've been doing since I was an intern at Bellevue. And I started shortly before first meeting Dolores Malaspina on this project. I've been studying the intersection of race with addiction medicine for about 2 decades, as it turns out. And I started at a time when the media was publishing stories about the surprise of white, suburban, and rural opioid addiction. My study quickly turned to how the US opioid crisis came to be seen as a white problem. And since that time, unfortunately, the plot has only thickened. I'll give you a hot off the press. So these are my disclosures. I have none really, and learning objectives. But I want to get to this slide. So this is hot off the press. This is something that a graduate student that I work with here at UCLA generated based on national data about overdose by race. And it turns out that 2020, as COVID was emerging, was the first year where Black overdose deaths exceeded the Black overdose death rate nationally exceeded the white overdose death rate nationally. So that is the white overdose death rate is the red line, the Black overdose death rate is the blue line, and you see how it began to accelerate around 2015, but now exceeds the white overdose death rate. The thing that's almost never reported in the media is Native American overdose death rates that were always as high or higher than white overdose death rates. So this is increasingly obviously also a racial justice issue. But of course, what makes the problem of opioid overdose different, of the past 20 years different in people's minds, is that the white identity of sufferers has very much been highlighted in the media. So I'm going to approach race and health from an angle that's unusual in medicine by looking at mechanisms of whiteness. I'm going to share a case study of the hidden but active maintenance of white exclusivity in medicine as a cause of what we often refer to as quote unquote health disparities among quote unquote underserved minorities. So these are words that describe this phenomenon in a passive manner as, lacking access to care. And so I'm going to argue that whiteness is central to our environment of profit motives, commodification, and the use of racial hierarchies to segment and open markets. It involves the mutual racialization of drugs and people, So drugs can be white, as in targeted to white consumers, and they can pharmaceutically enhance the whiteness of people whose privilege is in question because of stigmatizing diagnoses like addiction. So I first encountered office-based maintenance for opioid dependence in the late 1990s. I'm going to go to this, as a medical student working on the early clinical trials of buprenorphine, which would later be manufactured with naloxone under the commercial name Suboxone. And my attendings were excited about buprenorphine, which they said was about to, quote, change the culture of medicine by finally defining addiction as a chronic disease, treatable alongside diabetes, hypertension, and asthma in the same clinics, that is primary care clinics, and in the same way with pharmaceutical maintenance. So this caught my ear as an MD PhD student in cultural anthropology. I had to ask myself, what could it mean to change the culture of medicine? And what would drive a change like that? And as it turns out, my attendings were right. In the course of my career, I witnessed a profound change in the way that clinicians frame addiction. So my field of addiction treatment swang from a drug-free philosophy, meaning the goal was to get patients off of substances altogether. This was the early 90s, to opioid maintenance as first-line treatment by the 2000s. And as I completed an addiction fellowship and took a faculty position in psychiatry and anthropology, I also documented stark differences between buprenorphine patients and methadone patients by race and class. So what became a study of the culture of medicine became a study of how the opioid crisis came to be seen as white. So as represented in this graph, ironically, at the same time that racially targeted drug war policies led to mass incarceration of Black and Latinx Americans, giving the US the highest incarceration rate in the world. So these things happened in tandem.
Oh, no.
So I'm going to give you an analysis from my forthcoming book with sociologist Jules Netherland and drug historian David Hirschberg on opioids and race, based on research supported by NIDA, Robert Wood Johnson Foundation, American Psychiatric Association, and the New York State Office of Mental Health. And I want to just start historically on a historical note by saying that while narcotics have long been criminalized through association with marginal racial groups, so for example, 100 years ago, these images of Chinese opium dens that were luring unsuspecting white American women into sex slavery. And this is 1914 New York Times on cocaine crazed Negroes in the South that were attacking their work supervisors. And then a little later, Mexican marijuana madness. So these are racialized images of who is the addicted person that led to, they gave a lot of support to prohibitionist drug policies and the drug policies that we see today. What's very little discussed is this, that this was happening at the same time that symbolic association with white middle-class markets legitimated widespread prescription of narcotics. So this includes post-World War II barbiturates, which were widely prescribed, often to women, and went along with a very high overdose rate, actually, one that rivals the crisis that we see today, swiftly followed by benzodiazepines like Valium, that were marketed as suburban mother's little helper. We rarely ask, how can a drug assume whiteness within a pharmaceutical logic based on race? At the same time, this process of pharmaceutical whiteness is at the core of the question that this 2015 landmark paper raised. Why is the life expectancy of whites falling when the life expectancy of almost every other racial group at this point, 2015, was rising? And how did overdose become the primary immediate cause of excess death among white Americans? So I want to go beyond the received wisdom that unemployed white Americans in the post-industrial Rust Belt turned to opioids for solace. So that might be true, but it begs the question of why white Americans, why at that moment, and why opioids, right? So I argue that the current generation of opioids were designed to have white racial identities, and that in our stratified healthcare and justice systems, the social technologies shaping opioid consumption reinforce racial inequalities while at the same time harming white people. And key to this story, so I'll stay here for a moment. Key to this story is an unrecognized form of ethnic marketing that, because it targets white Americans, works by not marking itself as racial. So the story is invisible by design And it was only through years of observation and interviews with key actors that I was able to unravel the threads. So I've observed drug policy and addiction science meetings and clinical interactions over a decade and interviewed over 200 addiction scientists, treatment advocates, pharma executives, policymakers, administrators, prescribers. Let's start where I started this study, which is with buprenorphine, commercially packaged as naloxone. And this is the first, it's easiest to see its racial identity by comparing it to its predecessor, methadone. So this is a 2005 study. It was the first nationally representative study to compare buprenorphine to methadone patients by race and class. And then when I was at NYU, I followed that with mapping of New York City boroughs to document that the same pattern held in New York City. And then when I reached LA, I met a colleague who had done the same mapping in Los Angeles that confirmed the same pattern. And then a paper came out 2019, JAMA Psychiatry, that documented almost 20 years later that white patients who see a doctor and are diagnosed with opioid use disorder are 3 to 4 times as likely as Black patients to get buprenorphine prescription. And the most common form of payment is out of pocket for a very expensive drug that costs thousands of dollars to stay on for a year, followed by private insurance, and very low on the list, public insurance. So that gives you the race and class profile of the buprenorphine patient. But what we don't know from these kinds of graphs is by what process did buprenorphine and methadone gain their racial identities? So for that, we have to go back in time. So let's go back to 1965. Race riots were burning through Harlem, Philadelphia, and Watts, Los Angeles, and the unemployment rate was twice that for Black Americans as white Americans. So organized crime starts to recruit these unemployed Black and brown young people from inner cities to help them distribute their newly acquired East Asian heroin imports. And meanwhile, Rockefeller University metabolic researcher Vincent Dole, who thinks of heroin addiction as opiate receptor deficiency, analogous to insulin deficiency in diabetes. He publishes with colleagues findings from the first clinical trial of methadone maintenance. And the study subjects are African-American heroin injecting men from Harlem, so very close to where you sit right now. Its outcomes of decreased criminal activity and increased employment at 6 months. So decreased arrest and increased employment, that brings it national attention. By 1970, news of methadone as a pharmacological answer to urban heroin reaches President Nixon, who appoints pioneering methadone psychiatrist Jerome Jaffe as the nation's first drug czar. So Nixon introduces methadone to target inner city Black and Latinx Americans, as well as returning Vietnam veterans. And he saw methadone as the first weapon in his war on drugs. So to prevent diversion and street sale of methadone, the DEA regulates methadone clinics and requires daily observed dosing and regular urine testing. But due to community resistance to locating methadone in neighborhood, NIMBYism, the clinics are located in marginalized neighborhoods in the city, remote from other medical services. So methadone has long had only partial status as a medicine, as belonging in the mainstream of clinical care. It's been located outside and often very far from parent clinic and hospitals. So let's fast forward to 2002. A new kind of opioid problem has developed following Purdue Pharma's aggressive marketing of OxyContin as a quote unquote minimally addictive pain reliever. And most of these newly dependent people are white, many of them middle to upper income. The FDA has just approved the synthetic opiate buprenorphine commercially packaged with naloxone and branded Suboxone for maintenance treatment of opiate dependency in buprenorphine certified doctors' offices. So pharmacologically similar to methadone, in the same drug class, an opioid that blocks opiate receptors in the brains of addicted patients. Buprenorphine can be prescribed monthly for use at home, unlike methadone, which is still restricted to DEA-regulated clinics with directly observed dosing. So office-based buprenorphine represents a reversal of national policy. It is the first time since the 1914 Harrison Act that private doctors are permitted to use opioids to treat opiate dependence. And to accomplish this, the manufacturers of buprenorphine and the architects of buprenorphine policy had to distinguish buprenorphine symbolically and spatially from methadone. So buprenorphine, so pharmacologically in the same class as methadone, an opioid, buprenorphine had to be whitened. This is Mike in an internet ad for Suboxone. He's seated in his Ohio diner and flanked by American flags, talking of returning to coaching his son's baseball team and singing in his church choir after buprenorphine rescued him from a prescription opioid habit following a back injury. So I just invite you to think about the race and class imagery embedded in that, who is the addicted person who's appropriate for buprenorphine. But I want to argue that the ad was just the tip of the iceberg, that the whiteness of buprenorphine was actively achieved by specific social technologies. And one thing I wanted to mention is, just also think about the real reversal of the image of who is addicted that this ad is achieving. So back to social technologies. I'm going to give you an analysis of the white opioid crisis, of the quote unquote white opioid crisis of the past 2 decades in terms of what I call technologies of whiteness. That's social technologies of neuroscientific metaphors, policy and industry strategies that maintain racial boundaries around biomedical uses of opioids. And this scheme is informed by whiteness studies, which is an offshoot of critical race theory. And it proposes that one, whiteness is a category of exclusion and requires cultural and political maintenance of its boundaries. So in the US, not anyone can simply declare that they're white and partake of the benefits of whiteness in our society. Number 2, white race is unmarked. It's the assumed norm in the US. And for a century in the media coverage, it was rarely explicitly named, either in public policies or in the media. So for example, if you have picked up a newspaper article and read that an American was involved in something and no race was mentioned, chances are it's a white person. If race is mentioned generally over the past century, it's been someone who's not white. And the coverage of white people and white identity of the last 6 years or so is the exception that proves the rule. And I'll come back to this, but also in media content analysis that I've done, you see that when white race is being signaled in media coverage, often coded language like suburban is used to signal white race. Okay. Third, whiteness is defined by its other. So white on the one hand and black or non-white on the other hand are interdependent. Punitive American drug policy has long had a mutually defining twin of legal narcotics for white Americans who've had access to personal doctors, starting with morphine and then over-the-counter heroin for middle-class Victorian housewives, then moving to post-World War II barbiturates, stimulant diet pills, Valium, otherwise known as Mother's Little Helper, and now back to prescription pain relievers. Then lastly, white privilege has its costs. So not only do white consumers pay inflated prices for patented prescription drugs, but they pay with their lives in the form of overdose by lethal substances to which they have had quote unquote privileged access. So the 4 technologies of whiteness I'll be discussing include these, and I'm going to go to the first one, addiction neuroscience. So this is the least visible technology of race making, that of brain science. And we have to put buprenorphine development on the back, and by the way, OxyContin and sister products, newly patented sustained release capsules, on the backdrop of President Bush I's decade of the brain. So this was an era in which the National Institute on Drug Abuse, NIDA, was directed to look for neuromolecular bases for addiction in anticipation of breakthroughs from the Human Genome Project. And in the process, NIDA renamed addiction a quote unquote chronic relapsing brain disease. This was supported by leading NIDA researchers who co-authored this widely cited article in JAMA by the end of the decade of the brain. And in it, they argued that narcotics dependence was comparable to diabetes, hypertension, and asthma in terms of its heritability, treatment adherence, and relapse rates. And as such, it should be treated as a chronic medical illness, right? The scientists involved wanted this movement to have, or the scientists involved had a social justice intent. They wanted to destigmatize addiction by demonstrating that it's a legitimate biological condition and not a problem of morality or personal choice. What they didn't anticipate, though, was that the scientific universalism involved in that, because it implied a standard white male research subject, would help to open white markets to new opioids. And also that the unequal ways that biotechnologies are disseminated in this country, that would enhance the social stratification of addiction. So for example, brain images like this, by taking out the subject and his or her trappings of gender, race, and class out of the picture, by taking the offending organ, the brain, out of the body altogether, the image symbolically conveys an unmarked universality of addiction physiology. So you have no idea, who is this person? Where do they live? What do they encounter in their daily lives? So neuroscientists further reduced causation to molecular action at neuroreceptors, which is the ultimate disembodiment of addiction. The apparent universality of this molecular model implied an assumed white norm. It took a problem long associated with Black and brown crime and gave it a new implicit association with white Americans. In the process, though, it excluded social conditions. So the scientists involved wanted to counteract a drug war mentality by erasing the social context of drug use, but they paradoxically set the stage for renewed racial stratification of opioids. So what do I mean by that? Let's go to the next technology of whiteness, which is new biotechnologies. Neuroscientists unwittingly aided corporate strategists that capitalized on this erasure of the social. So building on neuroscientists' ideology of technological solutions for addiction, in 1996, Purdue Pharma got FDA approval for OxyContin as a minimally addictive opioid pain reliever suitable for chronic moderate pain. This was based on its sustained release capsule technology, which in theory lowered the reward for users by preventing an initial rush as oxycodone saturated the brain. The manufacturer influenced the National Joint Commission on Hospital Accreditation to call for pain to be aggressively monitored and treated as the fifth vital sign, along with heart rate, respiratory rate, blood pressure. And drug reps that were canvassing new OxyContin prescribers advised the prescribers as an additional safeguard to direct OxyContin to quote unquote trustworthy patients. And they did this along with brochures and ads that showed white middle-class Americans as, the consumers. So this language of trustworthy in a national clinical workforce that's been shown to suspect non-white patients of drug abuse, this implied to prescribers white patients, that this was a product for white patients. Of course, what the model of addiction-proof biotechnology left out was the social inventiveness of drug use. So OxyContin users interested in a rush of oxycodone to the brain quickly learned to crush and snort or inject the oxycodone in each capsule. And after steep increases in non-medical use of opioids and overdose, public pressure mounted for intervention. So by 2010, just as the original patent on OxyContin ran out, Purdue introduced its tamper-resistant time-release formulation of OxyContin, which embedded oxycodone into polymers that convert tablets into gummies should users attempt to crush and inject or snort them. By keeping prices high and representing OxyContin as technologically sealed off from misuse, the manufacturer strove to keep OxyContin symbolically a step ahead of urban non-white street markets. Another biotechnology developed specifically in response to white suburban and rural prescription, the white suburban and rural prescription opioid epidemic was buprenorphine itself, combined with opioid antagonist naloxone and branded Suboxone. So Reckitt Benckiser Pharma promoted this combination as a smart drug. Although buprenorphine is an abusable opioid, the naloxone with which it's combined causes withdrawal symptoms if it's injected, but not if dissolved under the tongue as prescribed, because naloxone can't be absorbed sublingually. So, and buprenorphine also caused a lower risk of overdose deaths than other opioids. In the 1990s, based on this concept of a smart drug, NIDA subsidized Suboxone's manufacturer with $23 million to test it for use in addiction treatment and sharply distinguished it from methadone, lobbying Congress and the DEA to lower the abuse potential rating of Suboxone from narcotics Schedule II, which is where OxyContin and methadone fall, to Schedule III, along with codeine cough syrup. And this is what made it possible to prescribe Suboxone in private doctors' offices. The manufacturer also lobbied Congress to get Suboxone included under an orphan drug clause designed to promote pharmaceutical development for unprofitable diseases in low-income countries, such as malaria drugs. Suboxone's designation got it a patent extension through 2009 on a drug initially developed in the late 1960s. So in a race and class stratified healthcare system, such as we have in the US, where access to general doctors is often, primary care doctors is often limited to those who can pay, patented, expensive technologies for private office delivery in themselves encode white, race, and middle class. So I'll go to the next technology, whiteness, which is regulation. By 2004, prescription opioids overtook heroin as the primary opiate of abuse in the US, and the arrest rate for their illegal possession was 1/4 that for possession of heroin. Arrests for illegal sale of prescription drugs was less than 1/5 that of arrests for selling heroin. Not coincidentally, the non-medical use of pain relievers at that time in 2004 was twice as high among white Americans as Black Americans, while rates of heroin use among Black, Latinx, and white Americans were almost identical. Since suburban and rural white opioid users were not politically popular targets for drug law enforcement, the DEA and other regulators focused their surveillance and enforcement on prescription opioid prescribers and pharmacists instead. And one sign of this has been the spread of prescription drug monitoring programs enacted in all 50 states eventually, half of which mandate prescriber participation with threats of loss of license and prosecution for those who prescribe opioids or other narcotics without checking a statewide database to see if it's been prescribed by someone else. And so New York is one of those states with threats of loss of license and prosecution around that. So this is an unprecedented kind of surveillance of doctors. Returning to buprenorphine, otherwise known as Suboxone, the Drug Addiction Treatment Act, Data 2000, that was passed in the year 2000, enabled any certified physician to prescribe Suboxone in the privacy of their own offices. And this was a huge breakthrough. So it was an act of Congress that reversed 80 years of prohibition of private doctor prescription of opioids for treatment of opioid use disorder. In congressional debates leading to the passage of Data 2000, there's a clear emphasis on a, quote, new kind of drug user, one that's, quote, young, suburban, and not hardcore. So this is coded language for white. And recorded testimony from federal officials stressed that buprenorphine was uniquely appropriate for a new kind of opioid user as opposed to methadone, quote, which tends to concentrate in urban areas and is a poor fit, that is methadone, a poor fit for the suburban spread of narcotic addiction, end of quote. So then Health and Human Services Director Donna Shalala was but one of many officials who noted that buprenorphine as an alternative to methadone would serve a, quote, new kind of addict, including citizens who would not normally be associated with the term addiction. So with this racially coded language in which suburban and new kind of addict referred to middle-class white Americans, Data 2000 passed Congress and reversed 80 years of federal prohibition of private physician opioid maintenance for opioid dependence. So, and I'll get to this in a moment, but Data 2000 kept the restrictive methadone system intact. It did nothing to alter the drug laws that mandated inner city heroin users to prison, but it did create a new treatment track with those with the resources to use it, and to give additional assurance to the DEA that buprenorphine wouldn't spill over into illicit markets. Buprenorphine's manufacturer, along with the Federal Substance Abuse and Mental Health Services Administration, SAMHSA, developed an 8-hour certification course that was required for doctors to prescribe buprenorphine. And buprenorphine became the first and only drug in the US to come with such an additional requirement for training and certification. So in my interviews with public sector doctors, they tell me that the certification requirement has been a major barrier to making buprenorphine available to low-income people because public clinics don't provide time or incentives for them to pursue certification. While prescribers, excuse me, in the private sector can charge fees of up to $1,000 for an initial induction visit for buprenorphine. The shortage of public sector prescribers, along with the cost of buprenorphine itself, have long kept buprenorphine in the private sector. Lastly, media and marketing is the last technology of whiteness. So OxyContin's legendary commercial success hinged on its designation as minimally addictive. And while OxyContin was under review at the FDA, Purdue Pharma estimated the addictive potential of OxyContin to be less than 1% based on testing among terminally ill cancer patients for a 3-month period. In 1996, the FDA accepted this claim and enabled Purdue to open an opioid market that had previously been restricted to people with severe acute pain, like post-surgical or cancer pain. And so they were able, with this FDA approval, to open a much larger market of patients with moderate chronic pain who were seeing primary care doctors. Okay, chronic pain like lower back pain. So this is analogous to SSRIs, with Prozac extending the population of prescribers from psychiatrists, making up a small percentage of the population, to primary care doctors. So enormously enlarged the market. So Purdue, in the first few years, hired 700 drug reps who canvassed a call list of 100,000 physicians and targeted general doctors in white, suburban, and rural areas, serving patients that the public and the DEA did not think of as at high risk for addiction. Purdue's strategy was successful. It led to a 10-fold increase in prescription opioids nationally, with disproportionate uptake by prescribers in white, suburban, and rural areas of states like Maine, Ohio, Kentucky, and West Virginia. In a newspaper content analysis that I completed, I found that in contrast to articles about the criminality of Black and Latinx drug users, suburbanites addicted to OxyContin were portrayed sympathetically in the media as victims of overprescription or as people struggling with physical or emotional pain. Ironically, Purdue's technological response to the first wave of white prescription opioid overdose deaths, their tamper-resistant formulations of oxycodone, combined with new prescription drug monitoring programs, led many of these new opioid users to look for heroin when pills, prescription opioid pills, became hard to get. And one consequence of this has been a whitening of the media coverage of heroin users who had long been portrayed as Black or brown. So this is a suburban school teacher from upstate New York, and this is a college athlete from Arizona, just two of myriad images that came out with this headline of the new face of heroin in the mid 2015 years. And the targeted intervention for these new heroin users, buprenorphine, otherwise known as Suboxone, was marketed to middle-class insured patients over the internet. Manufacturer web-sponsored, web-based public service announcements featured white professionals and business owners on Suboxone maintenance. So this is the National Alliance for Advocates of Buprenorphine Treatment. They're sponsored by Reckitt Benckiser Pharma, and you can see the race and class coding on this website. So this same website features a link to a Suboxone prescriber locator service. Look in the lower left-hand corner, patients find a buprenorphine physician, and you may, those of you on this call may have directed patients to this, where they put in their zip code and they get a readout of buprenorphine certified prescribers in their area. The vast majority of those prescribers will be in private practice. So these strategies together created an exclusive but lucrative segment of the market for Suboxone, making it a blockbuster drug at over $1.5 billion a year in US sales alone by 2012. In that year, 2012, second only to OxyContin, which reported US sales of $3 billion in 2012. So to conclude, this racial segmentation of drug markets into licit and illicit, white and Black, clinical and recreational, creates a moving, time-bound target of patents on new technologies that target the white middle class. And this is an old cycle, which was started by Bayer Pharmaceuticals' own heroin, which was marketed in 1898 as a non-addictive alternative to morphine among middle-class Victorian housewives, as well as a highly effective cough syrup for their children. So what can we learn from this as clinicians, researchers, policymakers? One, magic bullets are a myth. As the failed promises of OxyContin's sustained release capsule show, and of the inability of a unilateral focus on buprenorphine expansion to stem overdoses has shown, biotechnology alone cannot stop the harms of narcotics without systemic and social intervention. And to underscore that, I'm going to turn to an international comparison that's often used by my American colleagues who are advocates for buprenorphine expansion. So in France, where buprenorphine was adopted for general doctor treatment of opiate dependence in 1995, it was billed not as a stigma-reducing agent for a middle-class market, but as a public health intervention to stem overdose and HIV among low-income, largely immigrant heroin injectors. And buprenorphine was widely adopted among primary care doctors in France, in poor communities, in a country, and I need to underscore this, in a country with universal healthcare. So that's a huge difference between France and the US. They had universal healthcare, free healthcare for the public. The opioid overdose rate in France dropped 80% in the first 5 years after buprenorphine's approval. Contrast that with the US, where opioid overdoses are now well over 6 times what they were when buprenorphine was approved in 2002. And based on my interviews with white and non-white people trying to access and stay on buprenorphine, I suggest that the public health potential of buprenorphine is limited by our race and class segregated market-driven healthcare system, in which even when patients can access buprenorphine, which is difficult, they have difficulty staying on buprenorphine because they have patchy insurance coverage and tenuous access to prescribers. And one other thing, back to France. France has not only universal healthcare, but also a robust social safety net. And these are critical elements to their success with buprenorphine. The way that they use buprenorphine is that they've created community-based addiction centers located in heavily impacted neighborhoods that offer not only buprenorphine and methadone, but also comprehensive medical care, psychiatric care, and assistance with social needs. So housing, education and employment, childcare, peer navigation, so peer support, and also access to harm reduction. So not only syringe exchange, but supervised overdose prevention, supervised consumption facilities. There's one other thing I want to mention about buprenorphine in France. So you look at the year 1995 and you see the blue line, which indicates overdose death rate. So that's actually total number of overdoses. Okay, that's not the death rate. That's the total number of overdose deaths. So in 1995, at its peak, that was 565. So it's 565 people, period, in a country of 60 million people. Contrast that with the US, where the number would be, you would multiply that by a factor of, if not 10, 100, right? So it's closer to 565,000. So France never had an overdose crisis of the proportions that we had. And it turns out OxyContin was never marketed in France. Okay, France has a review body that looks at any newly patented medications to see if the data merits the medication be included in their national formulary. And they determined that OxyContin did not provide additional benefits and was not necessarily shown to be safe. So it never made the national formulary, and it was never marketed in France in the same, it wasn't marketed, it was prohibited because France does not have direct to prescriber or direct to consumer marketing. So these things, and they have a review body that is strictly made up of members that are strictly prohibited from having ties to pharmaceutical industry before, during, or after their service. Unlike the US, where many of the FDA, a number of FDA officials who approved OxyContin and sister products went on to take lucrative positions with the manufacturers shortly after the approval. So this should make us skeptical about the power of the market to protect the public and rectify inequalities in health. In our for-profit healthcare system, buprenorphine maintenance has followed the pattern predicted by theorists of fundamental causes of disease, Bruce Link and Joe Phelan, that new biotechnologies, okay, which are often introduced to quote unquote narrow health inequalities and, provide equal access to health care. New biotechnologies in a setting like the US, where we have very sharp social inequalities, if the social inequalities are not addressed, the new biotechnologies will widen rather than narrow health inequalities. And that's precisely what we've seen with buprenorphine. Okay, second take-home point. Addiction is biosocial. What do I mean by that? We should reconsider what it means that addiction is a chronic brain disease. Basic neuroscientists are increasingly seeing the brain as a plastic, socially responsive organ that's evolved to adapt to complex social systems. Emerging life science models of neuroplasticity, epigenetics, and the microbiome have underscored that human biology is not a fixed entity. It's rather dynamically shaped in interaction with the environment, including the social environment. So these more sophisticated biological models inherently call on us to invest in research on the impact of social systems, social environments, and interventions that create healthy social contexts, including robust social services, recovery support networks that give dignity, meaning, and structure to people's lives. So if we are to take seriously the comparison of drug dependence or substance use disorder with diabetes, asthma, and hypertension, then we'd recognize that each of these conditions has strong social determinants and that success in their treatment and prevention requires social support. Things like access to fresh foods, safe, unpolluted, walkable neighborhoods, and the list goes on. So that's where our focus should be. And then lastly, deaths of despair call for racial as well as economic justice. So let's go back to this 2015 landmark study by Ann Case and Angus Deaton, which reported the decline in US white life expectancy. This paper was unusual because its authors were not epidemiologists, but rather economists. And in fact, Angus Deaton had gotten the Nobel Prize in economics. Their analysis of root causes of overdose, as well as suicides and cirrhosis that explained this decline in US white life expectancy, their analysis lay not in neuroreceptors or in genetics, but in the deindustrialization of American Rust Belt towns, where the departure of manufacturing and mining industries left behind high unemployment and social disintegration. A sociological study following their report showed that overdose rates were linked to thin social networks. So spatial analysis, geographical analysis, the very high overdose rates were concentrated in areas with high unemployment and measures of thin social ties, small networks of support. Case and Deaton have popularized the idea with this, that overdoses are, quote, deaths of despair. So I find their argument persuasive in that it calls for social and economic revitalization of American communities through and policies that promote social integration, stable employment with livable wages and benefits, and not just public-private partnerships to develop, quickly approve, and disseminate new medications and biotechnologies for addiction, as have been prioritized in the NIH HEAL initiative, Cures Act, and other federal initiatives. But Case and Deaton's focus on white Americans makes the analysis incomplete, and it makes Black and Latinx overdose deaths invisible. Case and Deaton don't offer a clear explanation of why Black and Latinx life expectancy didn't decline in the 20-year time period of their study. But you have to ask, Black and Latinx Americans don't have higher employment rates than white Americans. In fact, they have lower employment rates. So I want to point out that Black and Latinx Americans saw an overdose crisis 30 to 40 years prior to white blue-collar Americans. With the influx of heroin to their inner city neighborhoods from the 1960s to the 1980s. Blue-collar workers in Black and Latinx neighborhoods were often barred from labor unions. They were the last hired, first fired, and they saw massive unemployment much earlier than white workers who were initially protected by industrial discrimination. So this earlier Black and Latinx opioid crisis was not seen as a health crisis. Rather, it was reported in the popular press as an epidemic of crime, which led to white flight from cities and further disinvestment from the tax base in what became Black and Latinx city neighborhoods. So we were then left with the survivors of that earlier crisis. Now, the new pattern of, I'll go back to this slide. Okay, so the slide that I started off with, the rapid increase in Black and also Latinx, as well as Native American overdose death rates, that has a lot to do with, number one, mass incarceration, because it turns out that overdose is extremely common in the period just after serving time in jail or prison. People have much lower tolerance to opioids. They are under incredible social pressures. They have been disqualified from many jobs and also from federal housing and local housing programs. They have very difficult time accessing medical care, including addiction treatment, incredibly high risk for overdose, coupled with the infiltration of fentanyl and other super potent synthetic opioids into the illegal market. So what's being sold as heroin now in New York City is largely fentanyl or other synthetic opioids that are much more potent and much more likely to cause overdose. So, okay, I'll just sum up. Take home points. As we work towards race and class justice and economic policy, we should use concern about the current opioid crisis to go beyond drug development and to invest in, number one, universal comprehensive healthcare of the type that I just described in France that has been effective, with attention to psychiatric comorbidity, trauma-informed care, peer navigation, recovery support, assistance with housing and employment. Number two, we need to nationally end criminalization and promote harm reduction and treatment instead of arrests and incarceration. Why do I emphasize nationally? Well, let's take New York City. Staten Island has been a pioneer in alternatives to incarceration. So local community activists partnered with the district attorney in Staten Island to create Project Hope, which offers people arrested for low-level drug charges to be, rather than sentenced, to be matched with a peer navigator and to get treatment. And they have gotten over 50% of the arrestees diverted from incarceration this way. Problem, Project Hope has been long at work in Staten Island and has not until very recently even begun to enter other boroughs, including the Bronx, so the South Bronx, where incarceration on drug charges goes on unabated and where incarceration is itself a social determinant, leading the South Bronx to have the largest number of overdose deaths in the city. So very patchy. If you leave it up to local initiatives, it will be locally empowered groups that get decriminalized. Three, biosocial and systemic research and intervention. So we need to invest in interventions that really do address the systemic and social determinants of overdose. And we need to invest in rather than searching for magic bullets, innovative biosocial community-based treatment approaches, including peer-based recovery networks involving the arts, urban gardening, community-based organizations, including religious or spiritual organizations involved in this. So I could tell stories, and maybe in the Q&A we can get to that, of these kinds of alternative initiatives. We need proactive measures to move us beyond incarceration on the one hand, and racialized for-profit biomedicine on the other hand, as our only responses to drugs, toward a public health approach that reduces the harm to both white and non-white Americans of our racialized drug industries. And so with that, I'll stop so that we have some time to talk.
That was just such an amazing conversation, education, perspective. I've seen some comments go by, but I would like to open this up to our audience, to people who have further questions. I have a question from Janie Simmons on when will your book be out? We've all heard the prelude.
Thank you. Because of COVID-related delays, both on my side and the press's side, I don't know how many of you have had this experience. The presses are really delayed because so many people, a lot of the presses are working in India, and so many people have died who worked in that industry. So it's very slow. So it's now pushed back to winter of 2023.
I hoped you would say that it was delayed because so many people wrote books during COVID, but that's sadder news.
And that's probably another factor. Yeah.
So, Ilyan Ivanov, did you like to ask a question? Wonderful, Ilyan.
Yes, thank you. Hi. Thank you for a great talk, really.
Thank you.
Very informative. I have a question. You mentioned something about how fentanyl now is affecting the rising rate of mortality in particular. And I wonder if you want to kind of elaborate a little bit on that, because I think that's the prevailing trend. I think people are dying more just because they're sometimes unaware, and these accidental deaths. And on the other hand, I think the available medication, including naltrexone and buprenorphine, are not as effective in the case of fentanyl because of the high potency of the drug. So if you share some additional thoughts.
Yes, so yeah, that's certainly the hot topic of conversation and drug research and treatment right now, is how to respond to this hyper potent, this whole generation of high potency synthetic opioids. And from my perspective, what's interesting to look at is the way that our policies and practices have fueled this. Because one thing that doesn't come up often enough in our conversations is, why is it that fentanyl has taken off the way it has? One factor is we've responded to drugs in general, drug harms, by criminalizing. And what that has done is greatly incentivized. So fentanyl comes on the heels of several waves of opioids. And I have told a part of that history, the advent of prescription opioids and their predominance, especially in rural and suburban areas by design through targeted marketing. Then people who have become dependent on opioids in these areas suddenly being cut off from their supplies by our policy responses, which is to restrict access. So surveilling and criminalizing pharmacists and prescribers and introducing these tamper-resistant formulations, thereby creating a huge opportunity for heroin cartels, right? That then can move into these neighborhoods where heroin had in the past been primarily restricted to large port cities because it's easier to smuggle there. But there's such an economic incentive to get heroin to these small town areas, rural and suburban areas, that heroin then took off because of the market opportunities. And then fentanyl being so much more potent and so much easier to smuggle to these areas, right? All of a sudden, incredible incentives to switch from heroin to fentanyl for the marketers. And so, I just want to highlight that is the result of marketing strategies, public policies. I've told the story of how different agencies, Congress, FDA were involved. And then we still have a supply side approach, which is to try to cut off illegal supplies of drugs like heroin, but greatly endangering people who have to go to the illegal market. So what happens when you use a criminalizing approach is you make the illegal supply so much more toxic. It's not regulated, right? And now there's a big incentive to increasingly sell as heroin very dangerous drugs. And so what I want to emphasize is the structural systemic factors rather than, just the surprise of fentanyl and what we can do biotechnologically. It's correct what you say, that fentanyl is so much harder to address on so many levels. It's really challenged our public health response. And I think we need to back up and look at how are policies enabling this kind of phenomenon, because we also need a shift in policy, not just clinical practice.
Thank you, Helena. Let's take a quick question as we round out the hour, first from Jesse Fields and then Kathleen Tracy.
Thank you very much, Dr. Hansen. I really appreciate your work.
Thank you.
I think it's really leading the way. I'm a primary care physician in Harlem. I teach in the Art and Science of Medicine course, and we definitely have been reading your structural competency article, and we'll go on and do much more. But my question is,
thank you.
In terms of, you're welcome, in terms of changing the focus in medicine really broadly on structural determinants and how trying to impact on those structural determinants, what you could say about that? How's that? It seems like a very major task, and there are local community organizations, some I work with, that are doing things, but it seems like we need to really broaden that and enlarge it and bring it out much more broadly, not only for medical students but also for practicing physicians. It's really a big cultural change in medicine, which, well, anyway, I just wanted to.
Yeah, extremely well said. Thank you. And this is a huge challenge. So if we were to really address the structural drivers of overdose deaths, we would be concerned with drug policies of the kind that I just explained. We could actually get quite a distance by decriminalizing these drugs, and not only placing treatment and outreach in clinics, but placing them in community. And it's very important to empower communities and place interventions there and support community-driven interventions. because clinical spaces are often very mistrusted, first of all, by our patients. I'll give you an example of a creative solution. So my colleague, Ayana Jordan, whose work you might have been exposed to, she's an addiction psychiatrist who got known for placing addiction treatment, recovery support with peer navigation, and harm reduction in Black and Latinx churches. So she created partnerships between clinical providers and church leadership, as well as people with lived experience. And reinventing the clinical space in that way has really opened up not only access, but changed the environment of treatment. Black and Latinx low-income people who use drugs are among the most marginalized in our clinical spaces. And they have had horrible experiences at the hands of clinical practitioners, and they will avoid our clinics at all costs as a result. So putting these services in trusted institutions, community institutions, and enhancing the team with community members and people with lived experience has made all the difference. So we would be moving in that kind of direction. And what it requires is for us to partner with advocates and people with lived experience to put political pressure for this kind of intervention. And what's my model for this? The AIDS epidemic. So how did we get so far with AIDS and including people with HIV on study section at NIH, and including them on community councils that make decisions about how HIV dollars are going to be spent, that led to housing to be a part of healthcare, led peer navigation, through that kind of political pressure, through partnerships between clinical advocates and people with lived experience.
So I want to just say the accolades are pouring in on the chat, but Kathleen, you have a last thought?
Yes, excellent talk, Helena. So nice to see you
Thank
again.
you. Oh my goodness. This is such a big reunion. This is
It is a
fantastic.
reunion, right? I had a question. This, you know how I feel about social determinants in health, and I think we share in this important.
You're a big role model for that. I just have to say.
Thank you. What can we do to shift funding opportunities towards this? Because while we talk about this, amongst our community so widely, the funding opportunities for this have gotten shrunk over time and have gotten relatively slow across funding institutions. So do you have any thoughts about what we could do to shift that, given its importance and its role in the systemic things that really, I guess, are the building blocks of substance abuse in some cases?
Oh, that is such an excellent question. I'm attempting to put in the chat. Okay. And I should try to, it has RSVP and registration information. Okay, so I just got off a call with the Drug Policy Alliance, which is hosting a series of panels on community-driven research in drug policy. And so I'm putting that up as a response because you put your finger on it. We will have to change the way that research is conducted and funded. And so this panel series by Drug Policy Alliance is just about that. How can we change the way research is conducted and funded? And they've invited NIH and NIDA, and they're trying to get a national conversation going. So it's an exciting lineup.
I'm going to have to end there and thank you that you could share that, Helena. We're a minute overdue. You deserve an hour overdue. But thank you to our wonderful audience, our wonderful speaker, and to the DEI committee. This has been very inspiring. Thank you all so much for coming.
Thank you.
Terrific. Thank you.